much better.
Okay. Hi, everybody. I hope we'll have a pleasant hour of discussion here. We want to introduce you to this whole system of treatment of first-grade deformities. Whether you want to fuse the MTP joint, you want to do a bunion, or you want to do a Lapidus type procedure, CrossRoads gives you a very interesting dynamic choice in what to do here. The agenda is very straightforward. I'm going to go through a quick algorithm of how I do it and how we think about we're doing things. Dr. Oji is going to go through the Dyna Bunion, which is basically the Lapidus fusion technique, which I tend to like a lot. Dr. Cavins is then going to go through the first MTP Fusion, which has been my staple for several years now. I think I have almost 100% fusion rate, but I'm going to publish that soon. And then Dr. Young is going to come out, going to talk to about the Mini Bunion, which I've been so enamored with that I can't talk about it because I'm pushing it on everybody because it's wonderful. And then we're going to have a panel discussion, some Q&A, and we certainly invite some interesting questions from everybody. Let's see where we go next. Okay, basically the thought process behind CrossRoads, which I've been working with for a number of years now, is your patient, your choice. Rather than try and force one system on every foot, this system gives you options for whatever you want to do for the foot, what you think is the best treatment option for the patient. And as I think you'll find out tonight, we'll have some different opinions on the best way to treat things. And that makes for some lively discussion. But there are three different systems that provide optimal implant fixation and stress-free instrumentation. This is the first MTP Fusion, fairly straightforward. I think we're going to run through a dynamic of it here. You look at it on the website, they play some pretty exciting music with it. But basically, there's a Dyna Bunion, the Mini Bunion, and MTP. So for a moderate deformity, or certainly any instability at the metatarsal cuneiform joint, you can get all the correction you want with the Dyna Bunion. And the cutting blocks are very easy to use. They allow for a lot of correction. And you can really dial in how you want to put this foot in here. And then these blocks to reduce it are wonderful. I've been using this plate for a number of years now, and I'm very happy with the fixation. Then they have options for 2 and 3 if you need to. First MTP, again, I think if you haven't had any exposure to staples, I've been really enamored with it. This is the Mini Bunion, and we're going to go through all these in much greater detail in a few minutes. So I just want to give you basically an overview here. Mini Bunion is a very small incision, and you respect the biology of the first MTP joint. You slide things over, and you hold it very permanent fixation. The key thing here is you can rotate that med head around and then do hammer toes and everything else as you might need to. Sometimes a lot of Lapidus with this. I mean, and Aiken with this. But and the trick with these are I get very quick healing, and we'll go through some more post-op course with these as well. Let's see if we can go on to the next. Okay, so basically a basic algorithm here is when you have a bunion, if you're unstable with the first metatarsal cuneiform, I think a lot of us are going to go straight to Lapidus type procedure with a Dyna Bunion. If you have a severe deformity greater than 15 degrees, the literature says to go with the proximal procedure. I had some experience with some earlier proximal procedures, it's including the rotational osteotomies. And we went above 15 degrees for somebody who left fusing the first metatarsal cuneiform joint. And I've now been pushing the limits with a Mini Bunion for that. And I'll explain why a little bit later on. Certainly, if you have bad arthritis, the first metatarsal phalangeal joint, I think most of us will do a fusion. And if things look pretty good and it's just a bunion, do the Mini Bunion. Exactly how high up you'll go to fix a Mini Bunion is going to be a matter of discussion. The key thing about the Mini Bunion is the very quick biologic healing and the substantial correction that I can get. Again, with all these, I'm getting very good healing. Something about the staple, that nitinol compressing across your fusion site has been practice changing for me. And so we're going to go through things in much greater detail. If this will let me get started with it. There you go. Can we progress ahead? There we go. Oh, don't want to give it away. Okay, so pre-op here is what would you do for this? And I'll invite the fellow panel members to talk about a 65-year-old gentleman with some basically kind of a classic bunion. He's got some lateral subluxation of his sesamoids. He's got second MTP synovitis and certainly some problems there as well. And I guess we'll start with each panelist and let me know what you do. Dr. Oji?
Yeah, thanks, Dr. Miller. I mean, I would probably do something you did since I trained with you, but I would probably, given the kind of mild intermetatarsal angle in this patient, the hallux valgus angle seems reasonable, and at least radiographically, I don't see a lot of frontal plane deformity. I would probably do a distal osteotomy. I'm a big fan of the Mini Bunion, so I would certainly do that. I would consider an Aiken at the same time. I haven't been doing a lot of McBrides anymore since you can get some great corrections with the Mini Bunion. And then to the second MTP, I would probably consider a short knee osteotomy with the plantar plate repair. I probably wouldn't do anything to the third or fourth unless he's symptomatic in that area.
Evan, what do you think?
Yeah, so for me, a lot of the decision-making process comes in with how stiff that joint is. So if the first MTP is really stiff, I don't like that tibial sesamoid being that far lateral. I have the sneaking suspicion that your lateral structures and your adductor hallucis is probably significantly contracted lateral to the first ray. So I would suspect that this patient would probably do better with either a Dyna Bunion or a First Mtp Fusion. But I think you could get away with a Mini Bunion as long as it was significantly flexible. And then, same thing on that second toe. Obviously, there's some retrograde force that's causing that metatarsalgia with that overlapping toe. But so that would be sort of my thought process. A lot of my decision making is clinical and not just on the X-ray. So I would just have the suspicions on that joint being flexible enough.
I don't echo that. I think the nice thing about these systems is you have lots of flexibility depending on what you see. Sometimes even when you get in there at surgery, and it's nice to have different options available to you. Dr. Cavins, what do you think?
Yeah, I agree with the rest of the panelists that definitely in agreement with Dr. Young that with the amount of range of motion that's there and like how if they're symptomatic at that joint as well, I lean more towards doing an MTP with these patients, especially at 65 and activity level. Sometimes they just do better right off the table. But if there is pretty good range of motion and they're not amenable to the fusion, then definitely doing the Mini Bunion might be a really good situation here. And then I completely agree with everyone else that addressing that second MTP and the hammer toe deformity maybe with it as well is definitely a good idea.
David, if you do a Mini Bunion, are you going to do a lateral release at the same time since you're at the second MTP joint or not?
Yeah, I mean, I think I would highly consider it. I would just see what the correction is after I do the shift of the first metatarsal. A lot of times, and depending on how flexible this person is, if he's very flexible, I find that it corrects well, especially if you can get a good 50, 60% or more shift of that capital fragment. But I would prepare to do it. I've been doing it more percutaneously through a small incision and using a beaver blade as opposed to doing the classical open release. And I've been doing separate incision for the second MTP.
Good. Well, let's see. So this guy got the Mini Bunion with an Aiken. And I did a wile osteotomy, and he was walking on it immediately. And I kept him kind of mellow for the first 3 or 4 weeks in a post-op shoe. And I think he's about 7 or 8 months out now, back to full tilt activity and very happy with everything, despite his ankle arthritis. So I'm pretty happy with this. And I kind of warn people might have to do something later with the arthritis of first MTP joint, but it's not been an issue for me. Any criticisms? That's what I'd like to hear. Okay, let's go another case.
Did you have to do a lateral release on that, Dr. Miller?
I think I snuck across and released my lateral sesamoid, but I didn't incise the capsule at all. And I try not to do that anymore. So here we've got an 81-year-old with rheumatoid arthritis, and things are a little askance. Dr. Oji, you going to go old school on me? What do you want to do here?
I mean, I definitely, I mean, fusion, 100%. I mean, I guess on the left side, I mean, definitely, I tend to just kind of go old school and do MTP fusion with metatarsal head resections on these and pin across the joint. I don't think there's any other option for this person's severe forefoot rheumatoid deformity.
Dr. Young, you agree?
Yeah, well, pretty much. I think the only thing that scares me as far as a fusion standpoint is that osteopenic bone. It just looks like there's not a lot of cortex there, but if you can get that to fuse, I think that's your best bet is First Mtp Fusion with a pan-met head resection. And that's that tried and true, works every time, just about. So
Yeah, Dr. Cavins, you seem to be agreeing as well.
Yes, sir. Yeah, wouldn't disagree with either one of them. Tried and true, First Mtp Fusion with pan-met head resection.
Got to put a couple easy ones in there, and that's what we did. And I was impressed with this plate, despite the osteoporotic bone, that we got a very quick and easy fusion, and she did very nicely with it. But you can see there, you got some pretty good compression of your staple through that osteoporotic bone. It really grabbed it down pretty well, and she did very well.
You went with the larger of the MTP fusion plate, Dr. Miller, as opposed to the standard one?
Yeah. I want to get as much purchase as possible. The other side was even worse, so we had to do a triple, and there we did a fusion with the MTP plates. And just to show you that, yeah, I'm pretty consistent.
Dr. Miller, did you do those procedures together at the same time, or did you have them spread apart?
No, absolutely the same time. Oh no, well I did one foot at a time, but yeah, I did the triple and the First Mtp Fusion as well as the forefoot Clayton Hoffman all at once, one and done. So here we have a failed TMT dislocation that was fixed with a mini tightrope that went on to instability and arthritis. And coming in with significant pain now, wondering, well, what we can do next. Dr. Oji, how are you going to approach this? Gosh,
unfortunate for this person. How long ago was the injury, Dr. Miller? I'm assuming it's chronic, but
it's about, I think about 8 months.
Oh, wow. Yeah, I mean, I think you're looking at a first and second TMT fusion. In this case, it's a salvage procedure. Now, I've had several of these Liz Frank injuries myself, similar where either they were not evaluated properly or treated properly. The Dyna Bunion works really well for these and so much more predictable than just doing a standard fusion. So I would definitely do a Dyna Bunion, even though it's not really a bunion, but fuse that first TMT, and I would just fuse the second TMT either with a keel log type staple or like a C-Max type staple. Looks like this person may have enough bone, so you can even use like a little plate staple construct from CrossRoads as well.
Dr. Young, how often do you have to go to 3 when you do 1 and 2? You do 1, 2, 3, or just 1 and 2?
Oh, that's a good question. I would, I'm not bashful about pulling the trigger on an MRI on these. If I look at an X-ray and I say that third TMT looks even suspect or narrowed a little bit, I'll just get an MRI and see if it looks like it has any kind of cystic changes in the joint or inflammatory changes. I'm fusing that. Just telling the patient, look, if it's not bad now, it's going to be in the future. So we might as well just do it. I think if you're doing 1 and 2, I don't really see the downside in doing 3. I feel like you're creating so much stiffness anyway. You might as well just prevent the potential issue down the road.
I kind of agree. I like to bring 1, 2, and 3 all together all at once, sort of thing. And if I leave 3, I think sometimes it's holding things open a little bit. Dr. Cavins, would you do 1, 2, and 3, or what would you do?
Yeah, I would definitely consider getting a potential CT or MRI as well, similar to Dr. Young. But if they're I'm with you. Definitely going to 1, 2, and 3 has definitely seemed to be better in the past few years for me. You know, if you would ask me this question maybe a couple of years ago, I would have considered maybe just doing 1 and 2. But now, just seeing all those patients post-operatively and how, you know, how they feel, you definitely have issues on that third TMT. So I would kind of educate the patient that, you know, considering those options and definitely lean towards fixing 1, 2, and 3 at Fusion.
Well, it's weird being the old guy, but I feel the same way, that this has definitely been my clinical experience to do 1, 2, and 3. And that's what we did. And I know we're not supposed to advertise things in the future, but CrossRoads is coming out with some good midfoot fusion constructs in the near future, which would be fun to do. So now we're going to go on to very specific items, and Dr. Orji is going to take us through the Dyna Bunion.
So the Dyna Bunion, it's a 4D minimal incision Lapidus system. It's very straightforward. Initially, you make the cut, and you get compression, or you cut, correction, and compression. You can really correct all 3-dimensional critical portions of bunion, including the transverse angle, including the IM angle. The most importantly, you can correct the frontal plane deformity and the sesamoid coverage, and you can also correct the sagittal alignment. So it's a very dynamic system, and it works very well. It's very straightforward to use. The great thing about this system, it really is reproducible. It really does save time. In the past, I would do it by hand and kind of hold the reduction while the residents would do cross wires and try to hold that reduction. It really decreases the stress level. It really makes it so much easier to correct the different deformities, and you can really get through majority of the case in about an hour or so. The case involves essentially, again, a transverse IM angle reduction, frontal sesamoid, frontal plane correction, and sagittal plane alignment. And then it also includes kind of the last kind of the 4 C's, as CrossRoads likes to talk about, which is compression, which involves kind of this RAC block or the rack block, which you see on the right here of the screen. And that provides compression through the first MTC joint. And you can kind of pin across it and kind of holds the reduction in place. So it's a very comprehensive system that's worked very well. So here's the kind of the RAC or the rack block. As you slide that gray piece down over the fixation pins, it actually compresses through the TMT joint in a linear congruent fashion, and it really does an amazing job of compressing through your cuts. And then you can put the Dyna Bunion plate over that with the staple plate construct with the anti-drift ball. It really does provide a very stable construct that is very manageable and fluid in terms of the process. So there are kind of new updates with the Dyna Bunion that is kind of starting to roll out over the next, I think in the last week and this week, and being sent to all the sites. It does involve a radiolucent reducer when you reduce the IM angle. The old one was metal. New one is carbon fibers, so it's radiolucent, so you can kind of see where the K wires are and better see the reduction, so that you can make sure that the metatarsal head is kind of over the sesamoids and properly rotated to correct the frontal plane. There's the greater blade, which is this kind of saw blade that goes on a TPS blade or saw. And it really shapes down any type of bony prominence very effectively. The kit now includes a Hinterman distractor so that you can remove the bone cuts, the very minimal sliver of bone cut made on the MTC joint. And then the rack block technique is a little streamlined so that you can leave the block on and just plate over that rather than using fixation wires. The radiolucent wire, I have used it a couple of times. It is very nice because now you can see exactly where the metatarsal heads are and how well the sesamoids are being covered, and you can see really the rotational correction that you're making. very effectively. And then the radiolucent reducer, also very nice because it's a little bit more streamlined. Again, you can really make the correction very nicely, and you can see that forefoot very well. Here's the gator blade, a graded blade. It really helps with the kind of the bony prominence, so especially in the medial aspect of the MCC joint, especially when I do a severe deformity and kind of rotate the first mat head, you will notice a little bit of prominence on that medial aspect. The grader blade does a very effective job of reducing that and making it a smooth surface, and it's so much faster than rondering. It really takes about a minute or two, so it is very effective. It's actually a very great product. I love using this thing because it's amazing. And then finally, the rack block. It's a little bit more streamlined. You can actually leave it now. I haven't played with that. I still do pins through there. I actually do a dorsal K wire through the rack block, and I do a separate K wire on the plantar aspect, directed proximally dorsally. I find that does not get in the way of my plate. But I'll be interested in trying this out and leaving the rack block on in the future. So here's just a case example or a quick demonstration. You make a dorsal medial incision, roughly about 3.5 centimeters. You expose the joint. You really need to free up the plantar tissue. You put the cutting block on, and you make your first metatarsal cuts. Here's a saw blade that comes with that. That's a little bit more narrow and longer. A pituitary ronger is very effective in removing that sliver. You turn it around 180, put the cutting block back on, and then you put the IM reducer on. Now it's radiolucent, and then you make the frontal plane correction, you pin it, and then you do the intermetatarsal reduction. And this is very powerful, reduces it very effectively. And then you can assess radiographically to make sure that you have good frontal plane correction. You activate the windlass mechanism by dorsiflexion the big toe. And then you pin it proximally, and then you make the cuneiform cut. Remove that. You use the pituitary ronger, which I recommend, and remove that sliver. You can always recut it if you need to. I haven't had to, but certainly that's a possibility. If you need to clean it up a little bit more, you can use a Hinterman to distract in the new sets. You can fenestrate or feather, your preference. I haven't, about 50% of the time, the cut is good enough that I find that I don't need to do that. But it certainly doesn't take too much time to feather or to fenestrate. And then you can put the rack block on and reduce it. You could either pin across there, or you could put the plate on directly. The rack block should hold the reduction in place. I haven't found that the K wires from the rack block gets in the way, but certainly you can pin it and remove it if you want to. Like I said, I do 2 points of fixation, one through the rack block and one separately through plantarly to hold the reduction. Any prominence, I will shave it down with the grater blade. And I typically use the Dyna Bunion plate with the anti-drift bolt. I find that works very well and effectively. I haven't really had to need to contour the plate. It does fit very well, especially with the grater blade, to make it nice and smooth. I typically put the staple in first. It's an 18 by 14 stagger staple. And then I put in non-locking screws proximally distally, and finally the anti-drift bolt, more of a to hold the reduction in place. And then of course the staple provides continuous compression, which is excellent. I personally use 3/5 screws. I really have to use locking screws unless they're kind of osteoporotic bone. I find that the non-locking screws holds it very well, and you have very good fixation. If I do use locking screws, I just do it on one side so that I can get continuous compression. You can measure directly off of the tower as well. And it is a variable angle screw if you need to do that. And then the anti-drift ball is a great screw, essentially the bow. You can angle it as you need to. It should go to the base of the second metatarsal. A lot of times I would rondure and curettage the medial cortex at the base of the second metatarsal so that you can get some fusion across that area. It is a cannulated drill bit. You just have to make sure that the screw threads are long enough. You want to drill through 4 cortices. You want to make sure that the screw is just past the lateral cortex at the base of the second metatarsal. You don't want to get that screw short. Just make sure you over drill it and get 4 cortices. All right, so let's get some case examples here. So I have a 69-year-old female with bilateral hallux valgus deformities, otherwise healthy. She's got a second crossover toe and obviously some lesser toe deformities, including hammer toes. So let's start with Dr. Miller first and kind of get his thoughts and kind of his treatment algorithm for something like those.
Well, as long as first MTC is relatively stable, I'll do a first MTP fusion on this with a second wild osteotomy, possibly a third, depending on how it goes. But usually, first MTP fusion will get you there with this one.
Is there anything else that you would do, Dr. Miller, like for the medial eminence or the medial prominence, or do you just kind of fuse it in place?
But when I do a first MTP fusion, I'll take off some of that medial eminence. It's just in the normal course of doing it, I think.
Then do you use, how do you prepare the joint surface? Do you use like a cup and cone reamer or flat cuts, or what is your preference type?
I do a cup and cone reamer. That's what I've been using for a long time. I used to do flat cuts, but as you know, my fellows would make the cut a little bit off and have to recut it. When I went to cup and cone, it was so much easier. Just line it up, and that way I can get the alignment right. And that's one reason why I really like the MTP plate is if the plate fits, you must commit. And you know, it helps me with the initial alignment. I put the plate on and then sometimes I'll pin it. And if the plate, and as long as the plate fits, I know I'm really reasonably good alignment right from the get-go.
Dr. Cavins, what are your thoughts on this patient?
Yeah, I mean, with such a large IM deformity and at 69, you know, I'm definitely in agreement with Dr. Miller. I would be leaning towards doing a first MTP fusion. But you know, that medial column and such a large IM, you know, definitely begs the question of, you know, is there something else I'm going to be able to do? But I definitely like addressing probably first MTP fusion for me here as well. And then going after the while and the second digit and trying to fix that plantar plate just to help stabilize that forefoot.
And Dr. Cavins, what is your technique for joint preparation?
I'm definitely cup and comb reamer with additional fenestration just to make sure we have a good amount of blood flow. For my proximal phalanx, though, I do actually like to run a drill bit throughout the entire center of the canal, not just fenestration. So I'm pretty aggressive on that proximal phalanx just to make sure we have pretty good blood flow throughout. And very rarely am I having to do flat cuts. Occasionally I'll do a flat cut if I'm having to do like a distraction arthrodesis. However, typically now it's mostly cup and comb reamer.
Dr. Young, what are your thoughts, sir?
Yeah, I'm going to reiterate the full agreement. I think you need a first MTP fusion on this one with probably a while and a plantar plate repair on the second. You know, I think you could get away with the lapidus on this patient if you felt like you could get that first MTP back, but boy, that I just don't think that's going to be stable enough. I think there's too much stretch on that medial capsule, too much subluxation on that joint. I don't think that would be good long term. Even with that big IM, I think you're going to get a fair amount of IM correction, especially if you leave the adductor hallucis attached to the base of the proximal phalanx. You're going to get a significant reduction. So, even if you only get 5 or 10 degrees, that's still quite a bit on this patient. It's enough to make them probably pretty darn happy. So,
oh, sorry, go ahead, Dr. Miller.
It's my former mentor, Dave Kacharin, wrote about with Roger Mann how if you do a first MTP fusion, you'll get a significant improvement in the IM angle over time.
Yeah, exactly. And stabilization of the medial column too. That's something else that's been shown too. So, yeah, for me, for joint prep, I used to be a cup and cone reamer guy. Did it for a long time, and then I had a scrub tech one time moved on me while I was doing my proximal reamer and shredded the skin pretty badly. So just one occurrence of that is all I'd ever want to live through again. So now I'm a rongeur and curettage to get all the cartilage off, and I flush it out really good. Then I finish straight with a 2.0 drill bit and just make the joint mushy basically and slam it together. So
yeah, I'm with you, Dr. Young. I think I've had 2 instances where the residents are a little overeager and kind of blew out either the mat head or the proximal phalanx. I still use a cup and cone for the first mat head, but for the proximal phalanx, I've been using a burr, rongeur, and curetaging that and fenestrating as well. I find that there's just a little bit, it takes a little longer, but a little bit better control at least.
Yeah, I think you can make your incision smaller too if you do it that way. If you do a reamer, I think you have to, you're literally just making a longer incision so you can get your exposure to do your reamer. Rongeur and curettage, you probably shave off half a centimeter to a centimeter on your length of your incision. But
very nice. So I pretty much kind of did what you guys thought, kind of discussed. I essentially did a MTP fusion. I did a second and third while plan and play repair. I was at 2 weeks, and then this is at 6 months. She went on to do very well. As you guys discussed, the IM angle did reduce. I didn't have to do anything special with the medial eminence. I did rongeur it a little bit, but that certainly reduced it. And then she had a very similar appearance on the other side. We did the same surgery. She's not back. She's a server working in one of the restaurants in San Francisco, and she's been very happy. All right, so here's a 38-year-old gentleman with a long-standing hallux valgus deformity in second toe that's dorsiflex. He actually has no pain on the second toe. He's actually very rigid in that first MTP joint. So in the exam, he really doesn't correct very well. So maybe we'll kind of reverse it and go with Dr. Young first this time and see kind of what his thought process and maybe treatment recommendations.
Yeah, so clinically, if I feel like the joint is stiff, if it's not causing pain, sometimes I wonder if just reducing the length on the first metatarsal will allow for enough excursion of the toe to not be so contracted. But on the other hand, you kind of wonder if it's just dysmorphic. I mean, you see the pasa there is kind of off, sublux significantly. I would probably lean towards a fusion, first MTP fusion. On this one, especially stiffness present in the toe. But yeah, I don't know. It's a tough call because the IM's not that big. The stiff joint's what throws you, and that's sort of the deciding factor on these.
Right. Yeah, that was certainly kind of a tough decision for me as well. How about Dr. Cavins? What are your thoughts?
Yeah, it's tough at the 38 and trying to, commit to a fusion, and even though it's, really been the standard for years, but clinically, if we're there and, it's painful and there's stiffness in that joint, I would hate to try to, just decompress and then post-operatively lead to, additional pain, when we were just there. So, yeah, I mean, unfortunately, I think I would probably, agree with Dr. Young as well. Really, probably go to a First MPJ Fusion and just explain and let the patient kind of understand where the decision is coming from, and let them know about. It's probably where I would agree to go to as well.
Dr. Miller, what are your thoughts, sir?
I think Dr. Young hit it on the head. It's a slightly dysmorphic foot. This is a funky foot when you're looking at it, especially at the lateral. And I don't like the obliquity of the first MTC joint. And I'm thinking that this might be more of a proximal osteotomy with some kind of distal release procedure or an Aiken. It's just weird. I'm really not sure what's going on. That first MTC is perfectly stable.
Yeah, I mean, he's actually fairly stiff throughout. So yeah, he's definitely not having the instability there, but he's just a stiff guy in general.
Yeah. I'd go more on clinical. I don't think I'd do a first MP joint fusion. I'd either do a proximal procedure or just keep it simple distally and see how he does. But there's something about proximally that bothers me on this one that I might go for the Dyna Bunion on this one.
Yeah, and I think those are great recommendations. I think everyone has very valid points. I actually ended up doing a Dyna Bunion for this gentleman. And for him, I definitely did a traditional lateral release, which really he needed to do. I did an Aiken. I resected the medial eminence, which I rarely do now with the Dyna Bunion. And I was very aggressive about reduction of the IM angle. Fortunately, with the kind of aggressive lateral release and getting everything mobilized, I was able to get it congruent. And this is at 9 weeks. I'm going to see him back in a couple of weeks, but he's been doing very well. And fortunately, it worked out for me.
The correction at the first is really impressive at the first MTP joint. It looks perfect now. So it's very, I think that rotation is a big deal to swing things back around.
Yeah, definitely. I think you're right, Dr. Miller. I mean, the Dyna Bunion really does help make that frontal plane correction very well. And the joint that looked kind of dysmorphic looks much more kind of normal in this situation. So
he had a little bit of a flat foot to begin with too, Dave. So I think you'll help with the stabilization of his whole foot with doing this. So I like it.
How about postoperatively with range of motion now at that first MPJ? Like how's he doing, and how well did what happened postoperatively with him there?
It is still stiff. He was kind of stiff to start off with, but he actually is kind of back to where it was. He really hasn't noticed too much of a loss, and I don't think he lost that much either. He does construction, so he just wears hard sole shoes all day. He hasn't gone back yet, but I anticipate he'll go back in the next several weeks.
That's great.
When you guys do like a Dyna Bunion, what are your kind of post-operative protocols? Dr. Young.
So I'm pretty aggressive with these as far as walking. I ask them to basically just go to the restroom walking for the first 2 weeks. And other than that, stay off the foot 100% of the time. But then at 2 weeks, if they're looking good and their incisions are healing well and they're not having a lot of pain, I want to start getting the first MTP moving. I know with that staple in there, I've just seen so much quick healing on these. I don't worry about them too much. So I just tell them, take it easy, use your boot, walk, you're allowed to walk around the house. You're allowed to go get a bite to eat, that sort of thing. As long as you have your boot on, you're fine. And then I tell them, if you're going to leave the house, use a knee scooter, use a crutch, something like that. But, any extended time period, get off the foot. But, a few steps here and there, go for it, as long as you have your boot on. And then around 6 to 8 weeks, if their x-rays are looking like these, I'm like, go for it, whatever you want to do. Tennis shoe. I tell them not to run or jump, obviously, or anything like that. But whenever they feel up to putting a shoe on around 6 to 8 weeks, anywhere in that time frame, I'm fine with it.
Dr. Cavins, do you use a boot or a post-op shoe, or what are your?
So I'm probably a little more conservative, definitely than Dr. Young. I initially start still in a posterior splint for the first like a week to 2 weeks. I really try to protect that incision up front and kind of leave them off of it. Usually after that first week, I see him back, I'll have him start doing range of motion at home. Just kind of help moving that first MTP. And then usually by that second week, though, I have them out of their splint and then into a walking boot. And I'm having them at least do some light walking, similar, to Dr. Young, with just go to the bathroom kind of around the house in the boot. But anything more extended than that, like I really try to keep them, off of it till about 4 weeks, and then I kind of let them open up a little bit more, and then right around 6 to 8, back to a sneaker based on whatever their swelling looks like.
Dr. Miller, what is your post-operative protocol?
I used to keep my Lapidus as non-weight bearing for 6 weeks, and then my friends in Grand Rapids taught me I could go much more aggressive with it now. So now I put people in a post-op shoe and let them do just heel touch weight bearing for the first week, and then full weight bearing on the heel alone for the first month. I'll see them back at 5 weeks. If we got good healing, then they progress to full weight bearing and normal activities. If they're a big, heavy patient, if they're clumsy, if they have some limitations, I'll put them in a walker boot and try and limit some of their weight bearing on it a little bit. But I've gone from being totally against weight bearing to some gentle weight bearing. Doesn't seem to hurt anybody.
How about your MTP fusions, Dr. Miller? Are you also letting them weight bear as tolerated early on?
I am. They go weight bearing as tolerated in a post-op shoe.
Oh, from the start, from the get-go.
Yeah.
Yeah, I'm the same, but in a boot. I feel more comfortable with them in a boot than I do a surgical shoe, and I don't know. That's just my comfort level. So.
Yeah, I'm definitely in a boot initially too. Right off the table, I'm okay with them like in a boot, but and then definitely give them a couple of weeks, I transition over to that post-op shoe.
It was like one of the people on the discussion asked about shortening to the TMT joint. Actually, the Dyna Bunion, you don't get that much shortening. Here's that 9 weeks post-op weight bearing X-rays to the right. You can kind of compare that to the, sorry guys. So this is the pre-op to the left, and then you can look at the post-op to the, so you get a very minimal amount compared to other instrumental Lapidus techniques. And then
Dave, I'll just comment on that, Dave, that I was a big believer in teaching the fellows how to make these real shallow cuts through the first MTC joints. And they showed me these cutting blocks, and I'm a total convert. It's made my life so much easier that I can't recommend it more highly.
I'm completely on board with you there, Dr. Miller. I think, when I saw the cut blocks, I was like, there's no way that's going to be able to take a sliver of bone off. And the first time I did it, I was like, holy cow, that's amazing. And then I would actually argue that these become almost functionally longer. I found myself jamming at the first MTP joint on occasion because you're essentially correcting the angular deformity and then creating, with all the contracture of the soft tissues that you've had over years and years and years, now you've got this tight joint at the first MTP. So I always cut it the first time and start doing my range of motion at the first MTP, and then I'll just recut the cuneiform if I need to shorten it a little bit more. And that seems to get my motion back. But yeah, I would say that it takes so little off. I mean, I haven't done a while on these. I bet you I've done 40 of these this year, and I don't think I've done a single while. So except for like a plantar plate repair or something like that.
Right, let's go to the last case here. 69-year-old female, fairly flexible first MTP joint, mild IM angle and hallux valgus angle, minimal frontal plane deformity. Dr. Miller.
Mini Bunion all the way.
Okay, and Dr. Cavins and Dr. Young, what are your thoughts?
Yeah, I agree. This is a great Mini Bunion.
Yep, and that's kind of what I did. Sorry, I was told to get moving. Sorry for the slowness there. But yes, I just did a Mini Bunion. This is at 6 weeks. And then 13 weeks, and she's done very well with this back to normal activities. You can see even at 13 weeks, you get so much abundant bony healing. It's quite amazing by preserving the biology there. I did include the aching because that's kind of what I enjoy. I feel like that corrects the extensors and the flexors well, and it cosmetically has a better appearance as well. All right, Dr. Cavins, I think.
Okay. Let's go move on to MTP. So the DynaForce staples from CrossRoads. The biggest thing we're going to kind of talk about, we got up top there, the different plate options is to really increase the torsional stability, and then having that plate construct kind of come through it. This really gives you a lot of compression, and really when you start comparing this to a lag screw, we have really three main big advantages. First being the gap recovery that is provided. The second being the apposition, you get that great bone-on-bone contact, and then really when you start putting these in, your speed will definitely increase within the operating room. Looking at these different size options for the MTP plate, you've got the standard option, and they can increase in size, really allowing for also varying types of staple length, and then you always have the option for either non-locking or locking screws. So how do the staple compression plates work? And we got a little video here we're going to start to watch. So the way the plates are designed, they have specific holes that allow for some range of motion along that dorsal aspect, and so that will allow for some dorsal compression. And then the length of the pegs will allow for that plantar area to kind of be absorbed, so that way you don't have this gapping effect. So when we all see these MTP fusions, and the last thing you want to see is that gaps start to form. And doing the MTP fusion with the staples is really kind of giving you that sense of security. There's some great videos that are out there that really do look at the tradition with the ice blocks. If you haven't seen them, we have hopefully one kind of coming up where you'll be able to compare the difference between the traditional plate and screw construct with the staple. I think we're going to hopefully watch one here now where they melt the ice, and all of a sudden you'll see that lag construct with the screw, everything kind of stays put. You don't really get any continued compression. So now when you have the staple kind of put in there, these are all with non-locking screws, you're going to start to see where this gap closure can really occur, and you'll see this at about 1.5 millimeters in total, and then we'll hopefully get to see that here soon. You can just see kind of how that kind of brings it now together, so you're not left with that gap that may be present leading to that non-union. And this is a great video kind of showing that the movement of those heads before the ice melts and then after. So there is that motion that occurs within the plate. And that was always something I found really fascinating, with CrossRoads, because I always had that same question: so how does this actually work? And seeing this, it's quite remarkable. And then you have different options. Remember, as I mentioned before, you can lock everything in, or you're able to do a non-locker, depending on the type of patient and the bone. Really, for me, lets me kind of determine if I'm going to do locking screws or non-locking, but definitely non-locking will give you more flexibility, and will definitely give you more closure across all of these sites. Hopefully that should be there. Watch that video again. Maybe kind of jumped ahead here. Go backwards. So I guess start opening up the question. So I have a first patient's here. He's got a contracted first MTP, 24-year-old male patient. Just plantar contracture, doesn't have any range of motion there. It's actually plantar flex down. What are your thoughts here? We'll start with Dr. Oji.
I would think some sort of, I guess, past medical history-wise, does he have any congenital syndromes or anything else we should be aware of?
He does. He was a cerebral palsy patient, and so he had minimal activity, but definitely still tries to walk and get around, and complains really of just pain at that joint. When you do try to load it, he just complains of pain that's completely there.
Got it. I mean, I think especially with CP not having to worry about, I mean, somewhat active, even high functioning. I mean, I think MTP Fusion would be a very appropriate option for this person. I'll definitely get it reduced. It'll be definitive. It wouldn't move once it fuses well, and you can maintain that correction well. That's probably what I would kind of lean toward.
Yeah, Dr. Miller.
Yeah, I'll have that as an option. First thing I'll do on these CP patients is I'll whack whatever tendon is pulling me into deformity. And sometimes you do an FHL lengthening or just a straight tenotomy and things straighten up. That's all you have to do. And if that doesn't do enough, then you have the fusion available in your back pocket to do it at the same time, depending what happens.
Evan.
Yeah, I totally agree. You might even consider, if you're having a difficult time getting that first ray down to the floor, you could even consider maybe pulling it through the metatarsal neck or something and anchoring it in, do a little tendon transfer there, almost like a reverse Jones suspension, just to try to get some more plantar flexion force in the first met head if you wanted to try something other than a fusion. But I mean, I think a fusion works great in this case. I bet you that would do the trick.
Yeah, I agree with you here. That's exactly kind of what we ended up doing. We're able to get kind of great compression, initially, and then this is kind of held without, we're looking at x-rays here that are about 6 weeks, and, there's really just and he's been trying to start to weight bearing on it, and I think we got great correction for him and got to get that thing straight. So he's definitely really appreciative of ever having that since he had that done. Next one here. Kind of similar story over here. We have more of a second ray pathology as well. Still we have this painful first MTP joint, more range of motion that's here, but still pain with dorsiflexion that kind of comes through. And then we have some second digit pathology. We'll start, going backwards. Dr. Young.
Yeah, I mean, there's clearly some subluxation at the TMT joint. So I'm looking at that, going, man, a Dyna Bunion looks like a decent option in this one. It's a strange declination on that first metatarsal too. Boy, it's a funky looking foot. How do you get Miries reduced, right? I mean, boy, yeah, I would probably lean towards. I'd probably lean towards Dyna Bunion. Is that AP? Is that first TMT? Is that like a chronic change to the first tarsal metatarsal joint there?
Yeah, it definitely appears to be so. He's not really symptomatic there. All the pain that we really get is driven right at that first MTP, and then he complains about the way his second toe kind of tries to want to sit over. But yeah, definitely radiographically that first MTP or that first TMT really does kind of jump out at you.
Yeah, so I mean, you could do a dorsiflexory first med osteotomy. You could do a first MTP fusion. I think just trying to center your treatment around the patient's symptoms probably be what I would do on this one. Just try not to get too crazy with it. And then if you wanted to go back later and do a Lapidus for a unstable joint or something, you could. But.
Dr. Miller.
Yeah, this is a paralytic adductus foot. So if you're going to do one, you're going to do 1, 2, and 3 and bring everything around. And it depends, again, what the patient wants and needs. If you do that, you're going to be immobilizing them for a while. If you just do a first MTP fusion and something with 2 to free it up a little bit, you might get away with a simple get-go for a while. That might be all that this patient needs. Kind of depends. You got to tailor it to the individual.
Mm-hmm. Dr. Oji?
Yeah, I mean, I don't think there's any easy, quick fixes with this kind of foot. I think I would lean toward MTC fusion to correct that first MTC. It definitely looks dysplastic and unstable. But again, I think everyone's correct in that. I think it depends on this patient's function and their preferences, activity level, and so forth.
Yeah, I mean, I really did try to tell him that we really should try to address that, first metatarsal joint there. And, the Dyna Bunion, I think would have been an awesome option for him, as well as addressing the second and third, just trying to help kind of swing everything around, and then addressing the lesser MPJs. But I'll show you, we ended up, they weren't interested in being, off of it for a little bit. They wanted to get more immediate weight bearing. So we just went with the First Mtp Fusion, and then kind of was able to get the second MPJ to reduce and some lesser capsulography work. And so I definitely, this is where I would say for me, I educate heavily on them, and I go, I think we've kind of addressed some of the symptoms that you have today, but just remember, down the road there could be some, sequelae to that, because radiographically there are issues. So I think that probably in this scenario, preferably I would have done, Dyna Bunion, but ended up here doing the MTP. Pass this over to Dr. Young.
So the Mini Bunion, probably one of my most commonly used procedures anymore. I'm kind of a First Mtp Fusion, Lapidus, or a Mini Bunion guy. I don't know that I've done a bunion correction without using one of those three options here in the last year and a half. And I really do love this Viking instrumentation and modification to it. It really has helped quite a bit, especially if you're dealing with having a scrub tech that's not familiar with you, or if you only have one assistant and don't have enough hands. This really frees up quite a bit. Plus, I found myself trying to do some stuff with it or without it that I haven't need to do anymore. So. Let's see if I can get this driving. So this is the Mini Bunion 3D system. Let's see if I can get this out of the way. So it is a true MIS system. Instead of lots of little incisions, 3, 4, 5 little incisions, you're just making the one slightly larger one. But people really do like this incision and the placement quite a bit. So yeah, so here's the new stuff, right? So you get the Viking ship. We call it the Viking ship. The Viking instrumentation would sort of be the correct terminology for it. There on the left, it just kind of helps with those percutaneous pins on the dorsal aspect to hold your correction, and helps you with stabilization as well as to help it reduce. On the right there, you can see they've really streamlined this system now. It used to be, you had to take the cut guide off and put another one on, and everything else was kind of, just tedious. Now you get your pin placed, you put your cut guide right over it, and then you just line it up however you want it, throw your pins, and you're moving on. So that is really nice. Get this video going. So this is one thing you can do, is they set up a bump. You want to make sure that your x-rays are in the appropriate alignment. That's a very important thing when you're doing this procedure. You want to make sure you map out your incision, both in the transverse, sagittal, and planes, just to make sure you're in the right alignment. I always try to lengthen just a little bit here. They're marking the joint to make sure that they have the first met head, and then where they're planning on making an osteotomy. Dealer's choice at this point. You can throw your pin first or make an incision first. I like to make an incision first, just just to make sure I have plenty of excursion room, but you can go either way. So there's your smaller incision. You can size it to a longer plate if you want to. I find myself using the small one almost every time, but if you want to go longer, here's the nice benefit of the cut guide. You throw your 2 pins, bend them out of the way, get your center pin out of the way, and you're ready to cut. So it's super easy. The Viking ship goes on. Sorry, I keep calling it a ship. But that goes on at this stage. You definitely don't want to do it at this stage. Make your bone cut. make sure it's nice and free. At this point, then you can load up your plate. I like using this little nitinol suture passer. I didn't use it for the first 15 or 20 cases. I found that I use it almost every time now. If you want to get a starter hole going, you can. I used to do this every time as well, just to kind of get a trajectory, get an idea of what you're doing. I think it's smart to do for the first 10 or 15 cases. Once you get used to putting this in, I don't know that it's as necessary. You do want to make sure that gets all the way down until the flare of the plate is touching the cortex. If you don't have that seated enough, you'll have problems later. You also want that angle of the plate to be medial distal to lateral proximal. That obliquity of the plate is important, and we'll discuss that some more later. Here's your oblique proximal screw. And really all this screw is doing, excuse me, really all that screw is doing is holding the frontal plane of the plate and not allowing it to migrate distally anymore. So reapply your Viking instrumentation. You're going to fix the frontal plane by rotating. If you also find the head getting a little too far lateral, this is a great instrument for bringing it back medial a little bit more. You'll probably have to have an assistant drive those pins in, but that's not too bad. You can use a threaded guide if you want to, or this is also off axis, so you could free drill this if you want to. And I actually have my favorite way of doing it, which we'll discuss later. You tighten everything up. You don't want to over tighten the oblique screw, just tight enough that it's 2-finger tight. And then you've got your little suture passer there. This is the percutaneous stitch technique that really helps to tighten up the medial capsule. Like I said, I didn't used to believe in it, and now I'm a every single time kind of guy. As soon as I do my lateral release, this is the very next step for me. And I do a lateral release probably about 85 to 90% of the time for these. The only time I wouldn't do it is if I felt like it might put it in varus. But that really does do a nice job of helping to stabilize it even further. And that's pretty much it. So a lot of things to consider when you're looking at these. So when you're looking at these preoperatively, I look at the shape of the head. If that medial first metatarsal head has this flare, such as in this picture, you're not going to get a lot of medial translation of the hallux. You just have to be aware of that. I always tell patients, there's a chance I might need to come out there medially a little bit more distal and just resect that portion of bone in order to get the hallux to move over. Sometimes it's fine, sometimes it's not. I just kind of want to be prepared for that. You also want to make sure you have a nice flexible joint. If the joint is not flexible, it's not going to move for you. I've done a couple of them where I was like, I'll just won't lengthen the first met. It'll be fine. Yeah, I wouldn't bank on that. I think that's fraught with potential problems. So if it's not flexible, I would lean towards a different procedure. So as far as dissection technique, I actually, like I said, I make my incision first once I get it all lined up. And then I'll actually stick a freer in there and I'll free up the extensor tendon off the dorsal aspect. And I'll just have the assistant put a freer or a Ragnell retractor in there and just pull the extensor tendon up. I don't even want to worry about that extensor tendon. You cut it one time and that's one time too many. Now you got a fully open procedure going, just trying to put the extensor tendon back together. So that is something you just want to kind of keep an eye out for. But other than that, there's really not a lot of dissection. You make an incision through the skin, all blunt dissection down to bone, free up the EHL. I always create a little pocket in the soft tissue distal plantar on the first metatarsal head, just to allow for the head of the plate to sit in the soft tissues when you go rotating that head a little bit. Oops, sorry. As far as osteotomy planning, if you have a big flare medially on your first metatarsal head, excuse my illustration there, but it really does help to get that plate back and seated behind the behind that flare. You can see down there on that X-ray, it increases the shift, sort of, whether or not you want to have that much shift. This actually looks good, but you can see that gap between the plate and the first metatarsal head that occurs if you're not seated proximal enough for that. Yeah, here's just another one where, I think I was probably just a little too distal on that osteotomy. You can see that my plate is touching the flare of the first metatarsal, and I'm trying to, I think I tried to like drive in that oblique screw a little further to try to, get that a little more proximal, and, would have just made it a little easier had I not done that. Started a little more proximal. As far as plate placement goes, you really, really, really do not want the plate to be parallel to your first metatarsal. You can see, again, in these illustrations, kind of the thought process. And again, excuse my terrible illustrations here, but on that bottom right picture, you can see how you want the plate touching the medial cortex distally and the proximal cortex laterally. And then if you get it too parallel within the shaft, you're actually just going to be transverse displacing your first metatarsal head. So that's something you'd want to look out for. The other thing that I try to do is I try not to allow any teeter-tottering of the plate within the canal of the first metatarsal. So as you see on that top left picture, I try to put my plate like it shows on the very top there, sort of dorsal distal proximal planar, so it's resting on the planar cortex proximally. That way, if the metatarsal head starts to drift dorsally and brings the plate with it, there's some protection against that as well. So just something else to consider when you're putting these things in. So here's your angle of the insertion. You can see in this the first X-ray in the middle there on the left. I think I was a little too parallel in the shaft, kind of transverse head, transverse malalignment or rotation didn't work as well. So you really want to get that thing as oblique in that canal as possible so that you prevent yourself from doing that. And you can see how I'm trying in the center X-ray to try to get that plate in there, moving from medial to lateral instead of just proximal or distal to proximal. So skiving off the cortex is perfectly fine with me. Yeah. If you over tighten the oblique screw, you got to think that oblique screw does move the capital fragment proximally, but it is not going to just provide compression. It's also going to walk that head laterally as well. So just kind of be cognizant of the fact that that screw is really designed to reduce rotation and to provide a little bit of stability. It's not really there to significantly compress your osteotomy site. So I always just caution people, make it snug. Don't be trying to tighten that thing down. Here's one where the medial cortex broke, and really it's fine. Actually, if you trim off the medial cortex after you get done putting this plate in, it's perfectly fine. There's no stability, not a lot of stability being provided over there. So the only issue with this patient was that they were able to feel the plate on the medial aspect there at the end of once all the swelling went down. So I thought I had some cases, I guess not.
I'll just add one thing with the, I was a little reluctant with that Viking boat aiming guide, but I found that these are a little bit difficult when you would reduce this. You'd have that head that could be up or down, or maybe not the right position. And with that Viking holder on top here, you pin it in place, you can check it with your mini C-arm and make sure everything's ideal. And it made it much easier for one person to do.
Yeah, I think one of my biggest frustrations was always I was trying to throw the distal locking screw, and I like to throw the distal locking screw freehand, and I actually shoot it a little oblique, distal oblique, because I feel like that gives you a little eccentric compression. That's your osteotomy. But, so you're trying to throw this freehand screw and you're trying to hold the osteotomy, hold the alignment, there's just too many variables that you're trying to account for. The Viking construct really helps to stabilize that so you can do that, and with confidence and not have to feel rushed either.
One more question for you is, I found a couple of people, especially one youngster, I had to trim the medial metatarsal head a little bit. It was just a butting on my plate. And I did that, then it fit perfectly. And so I'd say, don't be afraid to do it if you have to.
Yeah. I have extended my incision a few times just to make account for that, or even get a little, I think I used the grater blade one time, just poked it in there and just took it down a little bit. So yeah, there are options for that as well.
So I'm just going to give my history that, because I've been doing this longer than you guys have, but for 28 years, I've been looking for the perfect bunion. And I love what Giannini did with the percutaneous bunion years ago. We couldn't reproduce that in the States. I went to Europe and I had Louis Baruch teach me how to do a scarf. And that seemed to work okay. I did a bunch of those and they were lacking the rotational thing. And then the Wagner brothers taught me how to rotate with the promos. And I really do believe in the rotation. That med head helps. And I was actually in the midst of reviving the Revered and Laird when they came out with the Mini Bunion. And it threw all that to pieces. I didn't need it anymore because this did that rotational correction that I think helped me so much. So that's my perspective on bunions. It's nice to have everything in one stable. It makes it easy for me. I'd invite any of the people watching, if they have other questions, please add them in the question and answer so we can address them.
Well, it looks like there's one question from Dr. Miller here. It said, do you have any caution with the rack block and osteoporotic bone? Personally, I do not. I haven't had the guide wires pull through any poor bone quality. In fact, I probably use a higher number rack block, meaning you get more compression in patients with osteoporotic bone to try to just get better compression across there. But I'm not sure if the other panelists had any problems with the rack blocks and osteoporosis.
No, I think I don't typically see, or I guess I don't typically go for a Lapidus in an osteoporotic patient. I have had some softer bone, but it's not been an issue with the rack block.
I find it's been exactly the opposite, that those wires spread that force. When you bring it together, it's a much better spread. And instead of one screw, it sometimes pulls through osteoporotic bone. I was using a screw to reduce it. When I have the rack block, it's beautiful. It reduces it beautifully. It's been preferable.
Looks like the other question that one of the people watching this was about the shortening, which I kind of alluded to earlier with the Dyna Bunion. Again, the shortening is very minimal, certainly much less than other types of instrumented bunions. The sliver of bone is really amazing that you can get that much correction with so little bone removed. I forgot the exact number, but certainly it's only a couple of millimeters.
Yeah, I think it's 1.6 millimeters with each cut. Using the cut block, and then if you use the recut guide, it's one additional millimeter. So yeah, it's really not very much at all. I used to think that I did a better job using my curettage technique. I'm not sold on that anymore after I've actually been doing it a while.
Just all that I can emphasize as we're winding low on time here is the engineering with these CrossRoads equipment is seemingly simple, but it's really quite profound, and it's made my job a lot easier. And get your hands on the tools and try them. I think you'll really appreciate it.
I second that.
Go ahead, Dave.
Oh no, I second what Dr. Miller said. It's quite amazing. It's very well engineered. If you ever use some of the other kind of instrumented Lapidus systems, there's like 50 steps. It could get pretty arduous. This is reproducible, very simple to do. Mini Bunion, again, is very simple to do. And MTP Fusion, really, it's very streamlined, and it will increase your operative efficiency with the plate staple contract.
Dr. Wilmot asked how often you have to use a recut guide on the Dyna Bunion, and it's nice to have it there, but I've never had to use it yet. I know, Evan, you said you used it a couple times to shorten things just a touch more.
Yeah, I didn't use it very much at all. The first probably 15 or 20 cases I did, and then in the last 5 cases I've used it probably 3 out of the 5. And the reasoning for that was literally just because I felt like I took so little bone off at the joint. I felt like I needed to get a little more so that I didn't allow for jamming at the first MTP joint. So it's more of a more of just trying to keep the biomechanics of the foot functioning as normal as possible, and not so much about positioning or anything else on the actual osteotomy side.
Anything else to add, Dr. Cavins?
No, I think really I just definitely echo that what everyone really talks about, and just the simplicity of the system, and then how little everything kind of does actually come out. It's quite impressive, and for those that have never used it, I really think for all the questions, you really have to get in there and actually just start doing do a lab, and use those patients, and you'll be quite impressed.
Yeah, I would echo that. The other thing is that for someone who used to do lateral releases all the time, I've been really impressed with my mini bunions, how well they move afterwards. And as much as I believe in the MIS thought process, the other MIS systems are really difficult with a high learning curve. And this is very simple for me to do. And that's why I haven't gone to the total MIS, but this mini incision, I think, has a beautiful recovery rate with very little pathogenesis. I think we're about to wrap up. Yeah.
Thank you all. Thank you, Dr. Miller, for guiding us this evening. And thank you to all of the panelists. We really appreciate it. And lastly, thank you to CrossRoads for providing this webinar to everyone this evening. We will have the recorded version of this on FootInnovate if you missed any portions of it, hopefully within the next week or 2, and you'll be notified via email once it is available on FootInnovate. And if you have any follow-up questions, you can certainly send those to me, and I'll make sure that I pass those along. So thank you all for your participation, and have a lovely evening.
All right, thank you. Good night.
Thank you all.
Good night, all. Happy holidays.
Same to you guys. Take care.
Take care, everyone. Thank you.